All right, well, I'll go ahead and do introductions while we're waiting. And then we will get going and I will hand it over to you, Emily. But thank you so much for joining us at our webinar for our Coalition of Skin Disease members today on antimicrobial resistance. We have with us Emily Wheeler, who is the Director of the Infectious Disease Policy for BIO, which is the Biotechnology Innovation Organization. Emily is responsible for working with companies engaged in antimicrobial research, development, and commercialization, and leads BIO's antimicrobial resistance legislative and regulatory policy efforts. Emily is responsible for working with member companies engaged in antimicrobial research, development, and commercialization, and leads their policy efforts. She also is the director of the Working to Fight AMR Public Awareness Campaign. And we also have Amanda Jezek, who with us today, who is a Senior Vice President of Policy and Public Policy and Governmental Relations for the Infectious Diseases Society of America. Amanda is currently the Vice President for them, which represents over 10,000 infectious disease physicians and scientists. Amanda oversees IDSA's Public Policy and Government Relations Department with responsibility for policy development and advocacy on priority issues, including antimicrobial resistance, antimicrobial and diagnostic development, immunizations, preparedness, federal funding, and other issues related to public health and research. So we're really honored to have the two of you here today to talk to us about this really important issue, especially for the derm community to understand and know how we can also impact legislative efforts that you all are working on and support this really important work. So thanks so much. Emily, I'm going to hand it over to you to get us started.
Great. Well, good afternoon, and thank you so much to Kelly for the introduction and to the Coalition of Skin Diseases for the opportunity to be with you all here today to talk about AMR, antimicrobial resistance, which is one of the leading public health challenges of our time. As Kelly noted, there are some specific ties to the derm community related to antimicrobial resistance that both myself and Amanda will touch on today. A couple quick notes before we get started. I am recording this session today per the request of the coalition, so this webinar can live as a resource on the website and for other additional efforts related to antimicrobial resistance of the coalition. So we will be asking some questions and answers throughout, and we'll invite folks to extend those questions whenever you would like to. So just would like folks to be aware that this will live in perpetuity. I'll also note that there is a Q&A function in the Zoom, and we'll monitor that and respond to questions in real time. But we've also reserved some time at the end of the presentation today dedicated to Q&A. Great. For a little background on BIO. BIO is the largest biotech trade association in the world, representing over 1,000 companies across the United States and in 30 countries. Our membership includes over 50 companies that are working on innovative products that address resistant infections. Seeking solutions to the AMR crisis has long been a priority for BIO to ensure that clinicians and patients have the medicines that they need to treat serious and life-threatening infections. We work to raise awareness on this issue, to broaden the tent of advocates and organizations that engage on AMR, while working to advance critically needed policy solutions that address this fragile and failing area for medical innovation. I can't emphasize enough the urgency of the fight against AMR. AMR, again, is a leading public health crisis in the here and now and is only getting worse. Antimicrobials, so antibiotics and antifungal products, are the foundation of modern medicine and underpin procedures such as organ transplantation, major and minor surgeries, wound care, the care of immunocompromised patients, and more. And as folks on the line are likely aware, antimicrobials are also commonly prescribed for a number of skin conditions, including acne, eczema, impetigo, cellulitis, a variety of infections, and more. However, as we use antibiotics and in response to the use of these types of products over time, bacteria and fungi adapt and mutate, and they become resistant to treatments. This is the phenomenon known as antimicrobial resistance, or AMR. Life-threatening infections like MRSA are growing more and more resistant to today's antibiotics, which are truly limiting the options that are available to doctors and their patients. The slide you see up right now is based on some recent data that was released earlier this year, which revealed that drug-resistant infections were found to be at least partially responsible for 5 million deaths worldwide in 2019, with AMR as the direct killer of 1.2 million people. These staggering statistics reveal that AMR is now a leading cause of death worldwide, higher than HIV/AIDS or malaria. And further, by 2050, drug-resistant infections, which you may hear folks refer to as superbugs, could kill people, up to 10 million people around the world each year. That's higher than the annual death toll from cancer. So while resistant infections truly are a threat to everyone, everywhere, and successful healthcare provision is dependent on antibiotics that work, there is a crisis in the ecosystem and a need for action to ensure that we have the products we need to address this threat. AMR can directly impact individuals living with dermatological conditions in a variety of different ways. For example, diseases like eczema and psoriasis, which can cause a significant amount of itching, can lead to harmful bacteria and fungi entering the skin and the body. The number of infections these diseases cause often goes undiscussed. Antimicrobials also play a critical role in wound care and, of course, for all types of bacterial and fungal infections. Lastly, again, it's important to note that staph infections are becoming increasingly resistant, with MRSA becoming more common. The COVID pandemic has also exacerbated AMR. According to an analysis recently released by the CDC, the pandemic caused a surge in superbug infections and deaths in US hospitals. Amanda will speak to this in more detail in just a few minutes. But truly, the bottom line here is that action truly is needed now to address the fragile and failing antimicrobial ecosystem, to ensure that clinicians and patients have the drugs we need to address current and future resistant threats. Amanda, I'll pass it over to you. Could you please introduce yourself and share why AMR is a major priority for IDSA?
Thanks, Emily. Absolutely. So I'm really glad to be here today and appreciate everyone taking the time to join us here. So IDSA represents infectious diseases physicians all across the country. And these are the individuals who are seeing patients with some of the most serious, often life-threatening, most difficult to treat infections. And so IDSA has been working on the issue of antimicrobial resistance for nearly 2 decades now, raising awareness about this problem and advocating for policies to strengthen the antibiotic pipeline and to improve antibiotic use in order to improve patient outcomes and limit the development of resistance. This is the issue that keeps infectious diseases doctors up at night, even more than any other. And that's in large part because so much of our healthcare system was built upon the premise that we would have safe and effective antibiotics. In so many ways, antibiotics truly enable modern medicine. We are able to be incredibly bold with a variety of healthcare procedures like cancer chemotherapy, organ transplants, a variety of surgeries, because we know that these procedures can increase the risk of infection, but we'll have antibiotics available to support these patients. Unfortunately, increasingly, that equation is not adding up more and more often, in that we're seeing patients who can be successfully treated for cancer, who can receive a new heart, a new liver, a new kidney, who can get new hips, new knees, C-sections, all different types of surgeries. And unfortunately, then they are succumbing to these antibiotic-resistant infections when we don't have therapies available that are able to treat these infections effectively. So we're really facing what we often think of as a return to Civil War era medicine, an era in which we can no longer treat simple infections and instead have to amputate limbs in order to keep those infections from spreading throughout the body. That is a future that none of us want, and why we are advocating so fiercely and strongly for solutions to combat AMR. Can we go to the next slide? So I think as we all think about the lessons learned from COVID-19 and want to strengthen our preparedness, strengthen our public health infrastructure, we believe that antibiotic resistance is a preparedness issue, and that having an arsenal of safe and effective antibiotics is really a key part of our preparedness and our overall healthcare and medical infrastructure. So many different medical procedures, as we've talked about, simply can't be done safely without the availability of safe and effective antibiotics. And as we think about future outbreaks, future pandemics, other types of mass casualty events, any time that we have hospitals overwhelmed, lots and lots of sick patients, particularly patients on ventilators, we know that we're going to see some level of secondary infections, many of which will be bacterial or fungal in nature, and which will need antimicrobial treatments in order for those patients to have good outcomes. Even thinking beyond outbreaks and pandemics, other types of mass casualty events, fires, God forbid, terrorist attacks, other sorts of things where people have serious wounds or burns, those wounds and burns can very easily get infected, and those patients need antibiotics in order to have a good outcome. So we are confident that antibiotics really are a key part of our overarching medical infrastructure.
Thanks, Amanda. That's a really helpful overview, and it's clear that the infectious disease physicians that you represent are truly the ones that are on the front lines treating these patients that are increasingly having fewer and fewer options to treat these infections. I wonder if there's a story or two that you may be willing to share with the group to help demonstrate the situation that we're in now. To demonstrate really the threat of resistance and these experiences that your physicians are seeing.
Absolutely. So I talked about how we our physicians. Sorry, I somehow got muted. Can you hear me? Okay. So I mentioned that a lot of patients who have other types of healthcare issues, like cancer, organ transplant, surgeries, are often at greater risk for these antibiotic-resistant infections, and that's absolutely true. But we're also seeing increasing numbers of infections in the community from in previously completely healthy people who really had no interaction with the healthcare system. One story that I will tell you about is from a young woman named Tori, who, when she was a college gymnast and competed regularly, got a small scratch on her leg. It turned into a little raised bump. She really didn't think much of it. As it got larger and redder, she thought, oh, maybe I need to get this checked out. She was given a course of antibiotics and sent home. But she didn't improve. In fact, that what looked like a minor skin irritation got much, much worse. And she wound up in the hospital with a fever and with a much more systemic infection. She needed IV antibiotics. And the first couple of kinds of antibiotics she was given did not work. And her infection was getting worse and worse, to the point where her care team was having to talk about potentially amputating her leg in order to save her life. Thank goodness there was one last antibiotic left to try. That antibiotic did work. It saved her leg. It saved her life. And I think it really illustrates just how close we are to a post-antibiotic era, not just for fragile and medically compromised patients, but really for all of us. An era in which a simple cut, a simple scratch can become a serious and potentially fatal, untreatable infection.
That's a really powerful story, and I know I've heard others as well of folks going about their gardening in their backyard and having a small nick that that happens while using a trowel trying to plant your petunias, and next thing you know, going to the hospital and running through various different types of antibiotics since the first line, second line, third line are no longer working. So I think that's really a clear picture of the crisis in the ecosystem right now, and the tough decisions that physicians are having to make in these hospital settings to get the right approach and the solutions for patients. I think it's also important to dive into a little bit more detail about the impact of COVID-19. As I mentioned in opening remarks, we have seen a drastic increase in resistant infections and deaths from AMR as a result of the pandemic. Could you speak a little bit, Amanda, about why we saw that surge in superbug infections and deaths in U.S. hospitals? And maybe why or other causes behind that?
Absolutely. So I think this is terrifying, heartbreaking, and yet not at all surprising. So, if we think about particularly the early days of COVID-19, 2020, before we had vaccines, before we had a lot of different therapeutics, we had lots and lots of people in the hospital, very, very ill. Hospitals were overwhelmed. And when you have an overwhelmed hospital where it's crowded, where there aren't enough staff, where staff are burned out, exhausted, traumatized from everything that they're seeing, it creates a real kind of perfect storm for healthcare associated infections. And even before the pandemic, a lot of HAIs were multi-drug resistant. So you add in a number of factors to the pandemic, the fact that these patients are incredibly weak. Patients who are on ventilators, when you have to have that ventilator put into your body, that creates a very easy pathway for bacteria and fungi to get in and to grow. We also saw early in the pandemic high levels of antibiotic use, even in patients who did not have confirmed secondary bacterial infections. I think that was simply a symptom of dealing with this brand new disease, COVID-19, that we didn't know how to treat, that we didn't really have good therapies for, and patients being so incredibly sick that clinicians, understandably so, wanted to find some way to treat them, to support them, to help them get well. So we know high levels of antibiotic use can cause resistance. Overcrowded hospitals, very, very sick patients create a very easy environment for these infections to take root and to spread. I think that, we saw this 15% increase overall in hospital AMR infections and deaths. When we break that down and look at some of these specific pathogens, it's even more frightening, because if you think about the long list of resistant pathogens, some are even worse than others in terms of their difficulty to treat and their limited treatment options. And sadly, the top three that we see on this list, Acinetobacter, Candida auris, and CRE, these are three of the absolute worst, according to CDC, according to WHO, and certainly according to infectious diseases physicians. And so the astounding increases that we've seen here, I think are incredibly terrifying for everyone on the front line, certainly, and really should be for any of us who may need to get healthcare at any point in the near future. I think one other incredibly important point to mention here is that CDC and other infectious diseases experts do not expect these numbers to come down unless we make a concerted effort to bring them down. So it's not just, as COVID gets better, things will go back to normal. Once these bacteria and fungi take root, they are very strong and very difficult to kill.
That's really concerning. And I think that as we think about being prepared for the future, that last bit about a concerted effort needed to bring these rates down and back to pre-pandemic levels, and even lower, ideally, is really a point that speaks to the need for concerted action by the stakeholder community to ensure appropriate use in all settings of all antimicrobials, and particularly novel ones, and also the need for new options and alternatives to therapies that we have right now. I think there was also some impacts on community hospitals that I will pass over back to you, Amanda.
Absolutely. So, that the slide that we showed previously was kind of overarching, looking at the increases of antibiotic resistant bacteria and fungi in hospitals across the country. There was another study done that kind of split out large academic centers versus community hospitals, and found in community hospitals a number of these types of infections were actually much, much higher. And the authors of this study attributed that to really the lack of the infectious diseases workforce that is focused on what we call antibiotic stewardship, making sure that we're using antibiotics appropriately, and on infection prevention. And so I think this just really speaks to the fact that as we think about AMR, we need to strengthen the pipeline, and we also need to make sure that our healthcare facilities have the resources necessary to deal with AMR right there at the local level, and to make sure that we're using antibiotics optimally and that we're preventing every possible infection and every possible incidence of resistance.
Thanks, Amanda. Going back just one slide, I did notice a question in the chat about the increase in hospital AMR infections and deaths. I do not know the answer, but perhaps, Amanda, you may, if the infections were primarily in the lungs during COVID hospitalizations.
It's a good question. I don't have the numbers at my fingertips. Certainly we did see a lot of pneumonias, but I think keep in mind, these are very sick patients. So they often had IVs, they had central lines. And so we saw bloodstream infections and wound infections. People get infections sort of at the entry site for where they're getting IVs or central lines. So it becomes a wider array of infections than you might imagine, though certainly pneumonias are a large piece of that.
Great. Thanks, Amanda. And I think we've spoken a little bit about the connection between AMR and COVID-19. And I wonder, as we think about some of the lessons learned from COVID, what we may be able to apply to the AMR setting. I think, at least in my view, prior to the COVID-19 pandemic, at least in the circles that I'm engaging in, resistance or variants of a certain type of bacteria, fungi, virus were not something that folks were really commonly aware of. Now I think anyone, because of COVID-19, is aware of different variants of infections. And in the case of COVID-19, of course, that was a viral infection. We're talking about potential bacterial or fungal focus here, but a variant is the same thing as a different type, a different evolved version of these infections that we're speaking about here today. So I think there is an opportunity looking to pandemic preparedness activities to think about the fact that healthcare provision, as we've noted, is truly relying on antibiotics and antifungal products that work, and also that the bugs, these pathogens, they do not care about borders. They're going to be continually spreading, and we need to get ahead of research, development, and preparation before we see more of these staggering numbers that are frankly around the corner. Anything else from your side, Amanda, to add about lessons learned from COVID-19?
Well, certainly, Emily, I agree with everything that you laid out. I guess the only other things that we often think about as we think to the future is that these types of events, like whether it's COVID-19, a full-blown pandemic, or even smaller outbreaks, we can all expect that they're going to become more frequent for a wide variety of reasons: climate change, global migration patterns, greater interaction with wildlife in various parts of the world. All of these are factors that are leading a wide array of healthcare and public health experts to expect that we're going to see these types of events more and more frequently. And they're going to be increasingly complicated by AMR. So I think it just adds increasing levels of urgency for action. The other thing I would say, as we think about who are the most vulnerable during a pandemic or an outbreak, or really any kind of big public health emergency, we think a lot about people who are immunocompromised, and that can be for any number of reasons. That can be people with cancer, people with uncontrolled HIV. It can also be the increasingly large number of people taking therapeutics for any number of different autoimmune issues, including certain autoimmune skin diseases. Those therapeutics can often reduce someone's immune system. And so we're seeing an exploding population of people who are at some level of immunocompromised. And those individuals, as we've seen, are more susceptible to COVID-19 and to winding up in the hospital, and more susceptible to antibiotic-resistant infections, whether that's secondary to something like COVID or even just as a primary issue in the community.
I think the vulnerabilities are, of course, for those immunocompromised patients, and that has play particularly with some skin infections. But we're also seeing some broader health disparities as it relates to AMR. This slide here shows some of the key communities that are generally underserved, that may be disproportionately hit by resistance. And we know that in the broader healthcare setting, that risks related to different communities can be increased, and that's very much the same within the issue of AMR as well. We know that the risks for antibiotic-resistant infections are tied to social determinants of health, including where you live, environmental exposures, quality of healthcare, and socioeconomic and other factors that really contribute to disparities in health and health outcomes more broadly. Amanda, could you speak a little bit to the challenges of health equity as it relates to AMR?
Absolutely. So this year, I believe for the first time, CDC put out some data that really kind of pinpointed some of the key disparities that we're seeing in terms of resistant infections. And one of the key points that the CDC highlighted is community MRSA rates being significantly higher among Black communities in the US as compared to white individuals. And they listed several other different infectious diseases or antibiotic-resistant infections that have higher incidence among various communities of color, low-income individuals, and individuals with limited English proficiency. I think this was in no way a surprise to practicing infectious diseases clinicians, who certainly see those disparities day in and day out. Though I will say, I think that we would all be better served by much more comprehensive data, really demonstrating these disparities and allowing us to track those disparities over time, so that we can really get a handle on where our interventions are having success and where there are persistent gaps. But regardless, I think the picture is clear. We have serious disparities, and historically marginalized and underserved communities are bearing the brunt of AMR. And I think that this just, again, underscores the urgency for developing new therapeutics and making sure that everyone has access to high quality infectious diseases care and antibiotic stewardship, so that they have the best chance to get the best treatment, the right treatment at the right time, and get the best possible outcomes. I would add as well, we talked a little bit earlier about the impacts of AMR on various other types of health conditions, and cancer is really a big one because cancer itself weakens the immune system in many cases, and then the treatments for cancer often further weaken the immune system. And so there's just additional data here really demonstrating the impact of these resistant infections on patients with cancer. And I think highlighting that to win a war against cancer, we've got to have antibiotics.
Thanks, Amanda. I'm seeing a question that just came into the chat as well, asking if there are any additional insights on why health disparities exist around AMR in underserved communities. Is it the overuse of antibiotics in those communities, more exposure to superbugs? I know there are, earlier this year, there was a paper that was released by some IDSA physicians that spoke a little bit to some of these factors on why these communities are hit harder. Would be really happy to share that with Kelly to disseminate to this group as a follow-up to today's conversation. But also I'll quickly pass it to you, Amanda, if there's anything that you'd like to flag for reasons surrounding these health disparities.
Sure. So, as is so often the case, it's complicated. There are a lot of different factors, and it can vary depending on which specific population we're talking about and which specific pathogen we're talking about. So sometimes it has to do with more crowded living conditions. Sometimes it has to do with certain workplaces, particularly people who work in certain agricultural settings, meat packing plants, those types of things, where they may have greater exposure risk. There can also be issues around limited access to healthcare. And so that may lead people to be seen in an emergency room sort of after their infection has already progressed to a certain point, as opposed to being seen earlier on. It could lead to someone taking part of a course of antibiotics, or taking antibiotics that maybe had been prescribed and left over to a different person. Again, because people, when their access to healthcare is limited, they're not often getting sort of the best quality care. So there's a variety of different factors at play here.
Thanks, Amanda. Also received another question in the chat that is a really great segue into the next topic that we're hoping to share. The question was that we've heard of the increases in the numbers of MRSA, VRSA, CRE, and the emergence of new antibiotic-resistant infections over many years. What are the barriers to developing new, broad, and narrow-spectrum antibiotics? And what can patients and patient advocacy groups do to help move life-saving research and the development of new effective antibiotics forward? It's like the person posing that question was a mind reader of what may come next. So I think it's important to note for this group that as resistance continues to emerge and spread, we have fewer options for treatment of severe infections. And we need new products that can treat infections where others fail. However, there are limited novel options currently available, and the pipeline for antimicrobial products is already inadequate. We've only seen one new antimicrobial product with a new target approved in the last 30 years, and innovation is truly dwindling. There are only 64 new antimicrobial drug programs in any stage of development worldwide, and more than 80% of these candidates originate from small companies. We've seen the exodus of large pharmaceutical companies from antimicrobial research and development almost entirely, with only a handful of players still engaged due to the challenging environment to generate any sort of return on these types of products. I think in contrast to the 64 new antimicrobial drug programs for this area, there are thousands in the pipeline for even one type of cancer. So simply put, the antimicrobial ecosystem truly is on the verge of collapse. In 2018, an independent organization called the Access to Medicine Foundation assessed 20 companies developing AMR medicines. And today, 40% of those companies have closed down their AMR R&D programs. And the companies that remain, which again, 80% of which are small biotech companies, struggle to remain commercially viable. And many have either gone bankrupt or are on a path to bankruptcy. One example is a small company that was California-based called Acajan that reached FDA approval of a novel antimicrobial to treat resistant infections, and then filed for bankruptcy in spring 2019, less than a year after FDA approval. A second company with 4 antibiotics on the market filed for bankruptcy protection in late 2019, and then later restructured. We know that many other companies with recently approved antimicrobials or any antimicrobials on the market are on similar trajectories, and there needs to be a rejuvenation of the pipeline in order to ensure that there are enough treatments here for not only current resistant threats, but those that will come in the future. Because of all of these failures and due to the challenges unique to how antimicrobials are used, interest in this area of medicine has all but halted in the eyes of investors. And a recent analysis that Bio authored earlier this year found that venture capital funding of US antibacterial-focused biopharma over the last decade lags far behind other areas. And to the question that we just received from a member in the audience, you may be asking why the pipeline is thin and what the challenges here are to research and development. And the reason here is truly that the ecosystem and marketplace for these products is uniquely flawed. As we've discussed here, new and novel products are gravely needed to treat infections that are growing more and more resistant to available therapies. However, these new products must be used judiciously to preserve their effectiveness and prevent speeding up of resistance. Antimicrobial stewardship, as Amanda outlined, appropriately results in lower antibiotic use, which is what we want, but also leads to lower revenue for newly developed agents that clinicians and patients need in our armamentarium, but probably on a shelf until they're desperately needed. This is all good for public health because, again, we already have infections right now for which there are no available options, but it's hard for, if not impossible, for an innovative company to remain financially viable if their sole focus as a small company is based on this area. So again, the way that these antimicrobials are used creates an ecosystem that is fundamentally unique and really broken for these types of products. To help address the threat of AMR, the United States has had a robust response and has put in a number of measures to ensure that we are contributing to this growing threat. A few things such as government funding and different incentives to help support research and development by way of various programs under BARDA. Folks may have heard of CARB-X, which is an accelerator that helps advance early stage research and development for truly novel candidates. These are all really important initiatives that Bio supports, IDSA supports, and a broad community of stakeholders also supports. However, to stabilize and sustain the antimicrobial ecosystem right now, we urgently need policies that directly address the unique market challenges for antimicrobials. Stakeholders across different governments, academia, public health, industry, and many patient organizations acknowledge that commercial market reforms are the piece of the puzzle that is critically needed right now to ensure our nation has the AMR products it needs, and in particular, recommends implementing pull incentives like novel subscription models, as well as reimbursement reform that get at the post-approval challenges that are unique to these certain types of products. It's important to flag for this group that no single AMR policy solution is a panacea, but we'll take the next few minutes to talk about one bipartisan bicameral policy proposal that's gaining traction in Congress called the PASTEUR Act. Oh, there we go. The PASTEUR Act is a bipartisan bicameral policy that is gaining momentum again in Congress. PASTEUR would create a subscription style model under which the government pays companies set amounts for access to new treatments based on that treatment's value to public health rather than the volume of its sales. Again, in other traditional business models for other pharmaceutical products, the value that a product is able to generate is based on how much you are able to sell. In the unique antimicrobial space, we do not want to drive up use of antibiotics. We want them to be used only when needed to prevent from exacerbating the issue of resistance. Also to that note about appropriate use, PASTEUR would increase resources for antibiotic stewardship nationwide, specifically in under-resourced hospital settings and rural hospitals to help ensure that these novel products are only used when necessary. This new model would provide a guaranteed return for companies that are developing the most critically needed new antimicrobials, which enables them to continue innovating and also incentivizes investments to support a more robust antimicrobial R&D pipeline. If enacted, there's agreement that PASTEUR would truly be transformational to the antimicrobial ecosystem because it would drive sustainable investment to ensure that we have this diverse pipeline and make sure that we have sustained investment into remedies that address AMR. I know Bio has long advocated for AMR policies and most recently the PASTEUR Act, as has IDSA. I wonder, Amanda, if you could share a little about what policymakers are saying, first about AMR broadly, and then also maybe about the PASTEUR Act specifically.
Absolutely. So I mentioned IDSA has been working on this issue since 2004, so nearly 2 decades. I personally have been with IDSA since 2011, so I've been working on this issue for 11 years now. I can track it by how old my kids are. And I've definitely seen a real evolution of policymaker interest and attention to this issue. So initially, just the word antimicrobial, people would be tripping up and they'd say, what are you talking about? And now, when we talk with a lot of congressional staff, there is a much stronger familiarity with this issue. And I think that speaks to a lot of the education that a variety of groups have been working on, as well as to the fact that many more people now have had a personal experience with a resistant infection, or have a family member or other loved one who's had an experience, whether it's someone who's been sick in the hospital, someone who just picked up MRSA at the gym, you name it. There's been a real variety and sharp increase in, I think, the personal connections with this issue. I have not heard any office who have hit on the Hill who has said, oh, this isn't a problem. I'm not worried about this. We don't need to do anything. Everyone is concerned about this issue. It is truly one of the most bipartisan issues I have ever worked on in any organization. And I think there is growing excitement around PASTEUR specifically as a transformative solution. I've worked on a number of other AMR bills, some of which have gotten across the finish line and have helped us make some progress, others of which have not gotten across the finish line. But I've really never seen the kind of excitement among stakeholders and policymakers that I've seen around PASTEUR. I think there is this growing recognition, exactly, Emily, as you said, that this bill will be transformational. This is not just nipping at the edges of the problem, making a half step of progress. this is a big deal. This would really tremendously help patients. So I think the excitement around this bill is really growing. A couple of the sort of signs of that we were really excited to see, obviously more than 70 co-sponsors, and that's completely bipartisan, truly split down the middle, Republicans and Democrats. We were also really excited that President Biden included language essentially describing the PASTEUR Act in his budget request for 2023. And that language was endorsed in the Senate Labor HHS Appropriations Committee that was released earlier this year. So I think we're seeing continuous signals from the administration and from Capitol Hill around excitement for this issue. All that said, it hasn't been signed into law yet, so there's still really clearly some work to do, I think, to really help make sure that this gets elevated to the top of everyone's priority list as something that must get done as soon as possible.
Absolutely, Amanda. And I think couldn't agree more that the PASTEUR Act and AMR advocacy in general really is an all hands on deck approach. And the more oars are in the water moving this issue forward, the better. And we're really pleased to see such a wide array of organizations that have aligned behind PASTEUR specifically. There is a really strong push for the advancement of PASTEUR in any legislative package that is moving forward, be that something at the end of the year, which we are urging for, or if it goes into the next Congress urgently then as well. We have there's support from, again, over 150 organizations that really believe this is a priority and ought to be advanced, and really pleased to work with a diverse community of advocates to that end. Before we pivot over to the questions and answer portion of today, this also goes back to a question we already received about what can folks do. I think the key message to take away, if there is one from Amanda and my remarks, is that action really is urgently needed now on policies that directly address the fragile and failing ecosystem to ensure that we have the products we need to address current and future threats. We've outlined a couple actions here that raise the top, at least from my perspective. First, that would be for any folks that have perhaps experienced a resistant infection. All of those stories really go a long way. There is in the past, IDSA has cataloged some stories through a campaign called the Faces of AMR campaign. I know there are various other venues as well, and we would be all ears to hear any of those stories. Those really go a long way in any advocacy efforts, as I'm sure all are aware. Also, a call to action would be for folks to weigh in, including with members of Congress, about the increasing threat of AMR. And the urgent need for action on this issue. Even better, once you take a look at it, ask your representatives and senators to consider supporting the PASTEUR Act. Urgent action really is needed, and any voice moving forward this issue really helps. With that, I will pass it over to the question and answer portion. I invite folks to put any questions you may have in the chat or in the questions and answer function. I see one to get us started here. Perhaps for you, Amanda, as it has to do with guidelines, and we'll look out for any other questions from folks as well. Question here is that for hidradenitis suppurativa, the first line treatment is antibiotics, which rarely work. How do we go about changing the treatment guidelines to be in line with the AMR issue? This seems to be a juxtaposition.
So that is a fantastic question. So first I will say I work for a medical society, but I'm not actually a doctor. I'm the policy person. So I can tell you what I do know, which is that guidelines are typically written by medical societies. And so for a condition that is primarily treated by dermatologists, it is probably the American Academy of Dermatology that puts together the guidelines for that particular condition. And so reaching out to them to find out about their process and when they may be updating guidelines and when there are opportunities to weigh in on those updates. I know at IDSA, often when we develop guidelines, there will be opportunities for public comment and things like that. Many medical societies also follow something called the grade process, which is the way that evidence is judged in order to determine the level of evidence supporting a particular recommendation in a guideline. And so that is something else to kind of keep in mind about how guidelines get made and how they are updated as new evidence becomes available. But certainly I would say from IDSA's perspective, we recognize that it is critically important to only use antibiotics when they are medically indicated and appropriate, because we know every time we're using an antibiotic, it does contribute to resistance.
Excellent response, Amanda. Thank you. I just saw one more question come in. Can you speak a little more around vulnerability on those on immunosuppressant drugs in relation to AMR? Many chronic skin diseases are increasingly managed by systemic treatments like biologics.
Absolutely. So, in addition to skin conditions, there are a lot of different conditions that are now managed by biologics. And so sometimes those can impede someone's immune system. My understanding is that the level of immunosuppression can vary from patient to patient, depending on that person's overall health and other health conditions that they may have, their age, and a variety of different factors. And so certainly, people need to talk with their own physicians about what their level of immunosuppression may be, and what kinds of precautions they may want to take as a result. But I think in general, we are just seeing an explosion in the number of people who are immunosuppressed for one reason or another at one level or another of immunosuppression. And so the weaker your immune system is, the more susceptible you are to any type of infection. And now certainly that can include an antibiotic resistant infection. And if you get one of those and then we don't have a good antibiotic to treat you, that is a very concerning situation. But I would say it's even bigger than that. Because let's say you are immunosuppressed, you're at greater risk of getting something like seasonal flu. And we know that a lot of people still get prescribed an antibiotic for influenza, even though influenza is a virus and an antibiotic won't help you. This is a classic example of antibiotic overuse and misuse that's contributing to resistance. And so the more we can prevent infections by getting your flu shot, getting your COVID vaccine, getting any other medically indicated vaccinations, that is critically important. And I would say not only for the community of people who are immunosuppressed, but for all of us, because people who maybe can't mount a good response to a vaccine because of whatever type of immunosuppression they may have, they're really depending on that broader herd immunity. So we all have that role to play in preventing infections and preventing antibiotic overuse in AMR.
Thank you, Amanda. We are just about at the top of the hour here. I will pause and take a breath one more time to see if there are any late-breaking questions that any of our attendees would like to put into the chat. And again, we'll take the opportunity to really thank Kelly and the coalition for the opportunity to be with you all today to talk through this issue. And I'll go ahead and put contact information here on the screen. This is for me and my colleague Ashley from Bio, and happy to triage any follow-up with Amanda as well. I think There's one more question that is sort of a comment as well in the Q&A about prescribing behavior. And the comment is that much of what initial prescribers must adhere to is based on the cost of treatments, and obviously antibiotics are super cheap. Expensive medicines tend to raise flags by the payers, particularly before cheaper options have been tried. So, for example, generic antibiotics. So it's a vicious cycle, and I think both myself and Amanda would agree. And I think one of the things related to the use of particular products is that appropriate use means the right drug for the right bug at the right time for the right patient for the right duration. And that doesn't mean non-use of the bigger gun antimicrobials potentially at the outset, depending on how sick the patient is, and that impacting prescriber behavior obviously takes a long time, but these are the types of dialogues that many folks are engaging in right now to align with appropriate antimicrobial stewardship and to create the best outcomes for patients. Amanda, I wonder if you have anything else to add on the prescribing behavior question in the last couple of minutes we have.
Absolutely. I would say we want to make sure that every healthcare provider is empowered with the knowledge necessary and the ability to prescribe the right antibiotic for the right patient at the right time, even when that means no antibiotic, if that's what's indicated for that patient. I think one of the things that's so exciting about Pasteur is that it completely takes away the whole pay per dose type of a system that we have for antibiotics. And so we believe that does really empower clinicians to make the best clinical decisions for their patients without finances playing into that decision at all.
Thanks, Amanda. Great note to end on. Kelly, I see you back on here. I'll pass it over to you.
Yeah, thank you so much, Emily and Amanda, for your time today and for sharing all of this really important information. I know there's such a sense of urgency behind this, and I really am grateful for your leadership and for taking the time to just inform our groups on how we can support the effort and get involved in the discussion and really pushing this forward. So just want to say thank you so much again.
Thank you.